Hello dear friends, I am Dr. Darshan Dave and today we are going to discuss about the pharmacotherapy of myocardial infarction. Now, first and foremost, what are the learning objectives of today's session? First is, what is the pathophysiology? We will not go into the detail of the pathophysiology, but what actually happens in the myocardial infarction? What is the cause of the myocardial infarction? Then, what are the treatment objectives of the treatment of myocardial infarction? Because, dear friends, according to the treatment objectives, we will prioritize the objectives, and according to this, we will decide the drug therapy. Then, rationale of the drugs used in the acute myocardial infarction along with their dosage regime. So which drugs we are using, why we are using these drugs, how these drugs are going to be helpful, and in which sequence we have to give the drugs. And lastly, once the acute episode has been successfully treated, the measures you take for the prevention of secondary prophylaxis. It means that to prevent the reoccurrence of myocardial infarction. Now we will see very briefly about the coronary blood supply. Heart is supplied by the two arteries. One is the left coronary artery and second is the right coronary artery. Now just after the origin of the left coronary artery, it divides into one branch that is known as a left circumflex artery, and the rest is known as a left anterior descending artery. Why I have highlighted this branch? That is because of the majority of the part of the heart, and especially the ventricle, and again in this the left ventricle is supplied by the left anterior descending artery. And you all know that even though there is a need and the specific function of each of the four chambers of the heart, but it is ultimately the left ventricle that contracts and it will eject the blood into the systemic circulation. So I want to convey the message that if the left anterior descending artery will be blocked, then the major area of the left ventricle will be infarcted and the outcome will be very bad. Okay. Now if we still go further, that heart is made up of the three layers from the outside to inside: epicardium, myocardium and endocardium. In the epicardium, there are bigger epicardial coronary vessels present which supplies the epicardium, and from these bigger epicardial coronary vessels there are origin of smaller intramural or intramyocardial penetrating branches, perforating branches, which will supply the endocardial region. So even though the bigger epicardial vessels are there, but the supply of the endocardium is dependent on these smaller intramyocardial perforating branches. Whenever the intraventricular pressure increases, now this pressure increases because of the intraventricular volume is increases. Because of this there is an intraventricular pressure increases. Because of this there is a ventricular wall tension is increases. Even during the diastole. I am not talking about the systole. We are focusing on the diastole. Now why we are focusing on the diastole? Because heart receives the blood supply during the diastole. And because of the raised intraventricular wall tension, these penetrating branches, intramyocardial branches, they will constrict, they will squeeze just like the uterine vessels. And because of this, the subendocardial region, they receives a very less blood supply. And this is known as a subendocardial crunch. So it means that whenever there is an end diastolic volume is increases, so the end diastolic pressure is increases, so the ventricular wall tension is increases, and because of this there is an occurrence of subendocardial crunch. It will be helpful for the understanding of the later aspect of this lecture. Now, what is myocardial infarction? You all know that ischemia means there are cellular changes occurs due to the decreased blood supply as compared to the demand, and if it progresses, then it will lead to necrosis, means complete cell death. Now, myocardial tissues, they are very vital. They cannot survive for even for a few seconds without the presence of the blood supply. And so the myocardial infarction is an ischemic necrosis of the portion of the myocardium, and that is due to the sudden occlusion of a branch of coronary artery. So what should be the treatment objective? First and foremost is the relief from the cardiac discomfort. Okay, now here I want to briefly speak something about the clinical features. Now, in the myocardial infarction, the typical clinical feature is the patient experiences the pain that is a squeezing and constricting type of the nature, and obviously it occurs over the region of the heart, but it will radiate to the neck, to the back, to the axilla, to the left arm, and even up to forearm. And the patient is typically saying that such type of the pain I am experiencing first time in my life, and there is a feeling of sensation like impending to death, and that's why there is an associated tremendous anxiety and apprehension. So the first treatment objective is to relieve from these symptoms triad. Then next is, here the whole episode of the myocardial infarction is due to the blockage of the coronary vessel, and that's why the perfusion of the myocardium is hampered. So the next time is we have to ensure the reperfusion of the myocardium. Then the next is, there are chances of development of many complications like arrhythmia and shock. So our first aim is to prevent the complication, and if the complication already occurred, treat the complications. And many times, even after the initial thrombolysis or initiation of the reperfusion, after some hours, again there is a rethrombosis because the vessel is damaged, and you know that the damaged vessel will lead to the aggregation of the clotting factors, platelets, everything, and again there is an rethrombosis. So we have to prevent this rethrombosis. And lastly, even after the successful treatment of the acute episode of myocardial infarction, our aim should be to prevent the further episodes of myocardial infarction. That is known as a secondary prophylaxis that we have discussed. So pharmacotherapy of myocardial infarction, it is an emergency condition, and the treatment is divided into the three parts. The treatment that is given before the hospitalization, there are certain drugs that are given at the home or during the transit to the hospital, that is the treatment before the hospitalization. Then the major amount of the treatment given during the hospitalization in the ICU, and certain drugs that are prescribed, certain non-pharmacological measures that are advised after the discharge for the secondary prophylaxis. Now, which treatments given before the hospitalization? Now, when the patient complains such type of chest pain, immediately the patient has been given a tablet aspirin, the usual aspirin, that is 162 to 325 milligram, and patient has been immediately instructed to chew the tablet and to swallow the tablet, and the purpose is to achieve the plasma concentration of the aspirin as early as possible, and that is sufficient to achieve the antiplatelet action, and we will achieve the antiplatelet action at the required site. That's why the purpose of chewing before swallowing is very important. And the second is sublingual nitroglycerine 0.3 milligram. This is given to relieve the chest pain. Now you all know that nitrate is a coronary dilator. Actually it causes the selective coronary redistribution, and that's why increased amount of the blood supply to the ischemic area, that is definitely helpful for the relief of the pain, and additionally nitrate reduces the preload and the afterload. But suppose the pain is not relieved within 5 minutes, then you have to give an additional dose of nitroglycerin, same 0.3 milligram sublingually. Still, if the pain persists after 5 minutes, then you have to give the third dose. But you have to stop at this juncture. You cannot give the nitroglycerin indefinitely till the patient reaches to the hospital, because nitroglycerin is a vasodilator and it will lead to significant hypotension and even the cardiac failure also. That's why maximum 3 doses of the nitroglycerin can be given. Now, aspirin we are giving, as we have discussed, for the antiplatelet action, and the nitroglycerin that we are giving, it is for the relief of the chest pain. But many a times the pain is so much, as I have told in the previous slide, that patient will tell that that the pain that I have experienced, I have never experienced such type of pain in my life. Okay, and you all know that the opioids, they are a very powerful analgesic, especially for the visceral pain, visceral smooth muscle pain, and that's why if it is not controlled with the nitroglycerin, one can give injection morphine 1 milligram per minute intravenously and repeat after a periodic interval up to 10 milligram. Now, why I have not mentioned this before? Because the reason is that it is not easily available. Otherwise, morphine is a very good analgesic. Second thing, morphine, because of its central action, it will reduces the anxiety and the apprehension, and that's why the patient will feel somewhat better. And third, when you give morphine intravenously, it will simply shifts the fluid from the pulmonary to the systemic circulation, to the peripheral circulation, and that's why the load on the heart will be reduced. Okay, but as I have told you, the availability of the morphine is very limited, but there is another morphine congener, that is buprenorphine, that is easily available, that can be given. Okay, so we are using opioids for the relief of the chest pain, anxiety and apprehension. Now, which measures during the hospitalization? Okay, now one thing I have forgotten, that even before the hospitalization, one point must be taken care by the patients and his or her relatives, that absolute bed rest, because if you do even a slightest movement, it will increases the cardiac workload, and the same applies during the hospitalization. Complete bed rest, and second is that 100% humidified oxygen, then intravenous nitroglycerin, thrombolytics, beta blockers, AC inhibitors, anticoagulants, IV fluids, and treatment of the complications, if any. Now, these are the armamentarium of the drugs. We will see the role of each drug, what in which sequence this drug should be given, how these drugs are going to be helpful, what are the advantages, which precautions or which measures to be taken while prescribing this drug. Okay, in the next slide. Okay, so during hospitalization, in addition to the obviously the patient is admitted in the ICU or ICCU, and there is a complete bed rest along with the 100% humidified oxygen will be given, and in addition intravenous nitroglycerin can be given, but with the condition that patient must not be having hypotension. Okay, because even if the patient has been given sublingual nitroglycerin 3 tablets before the admission, but if still the chest pain persists because of the coronary vasodilatory as well as the cardiac work reducing action of the nitrate, it can be given as an intravenous infusion. Now the dose here, even if I have mentioned 5 microgram per minute IV infusion, but it is dependent on the vitals, especially the blood pressure. But you have to be very cautious, and there are certain absolute contraindication of the nitrates in case of the myocardial infarction, and that is As I told you, hypotension, so the systolic blood pressure is less than 90 per minute, or the heart rate is less than 50 or more than 100 beats per minute. You can definitely understand heart rate less than 50, but why it is contraindicated when the heart rate is more than 100 beats per minute? Because nitrates are the vasodilator. If the heart rate is more than 100 beats per minute and if still you are giving the nitrates, there are chances of tachycardia, which will further aggravate the cardiac work and which will worsen the condition. And the last, but it is very important, is that if the patient's relative or patient himself tells the history of taking sildenafil in the past 24 hours, then forget about the thinking of giving intravenous nitroglycerine. Okay, then the next is, so this was our first aim that has been fulfilled, that the relief of the pain and the cardiac discomfort. Second aim is we have to start the reperfusion. Okay, the perfusion, the cardiac perfusion has been stopped because of the thrombus formation and occlusion of the coronary artery, which can be re-established if we give the thrombolytics. And these are streptokinase, urokinase, and a recombinant tissue plasminogen activator, that is alteplase. Okay, now what the thrombolytics will do, as the name suggests, it will causes lysis of the thrombi. They act on the plasminogen and convert it into the plasmin, and these plasmin acts on the insoluble fibrin polymers and convert them into the soluble fibrin fragments, which can be easily broken down. And that is how the thrombolysis will occur. Now, but one thing must be keep in your mind, that these thrombolytics are effective only and only if these are to be administered within 30 minutes. After that, their effectiveness gradually reduces. And the second important thing is that these thrombolytics are effective only in the ST segment elevated myocardial infarction. This is known as a STEMI. They are not at all effective in unstable angina and non-ST elevated myocardial infarction. Then the difference between the individual agents. We have already discussed about the thrombolytics. Streptokinase is the first to be discovered, but as the name suggests, it is obtained from the beta hemolytic streptococci, and it is the cheapest one, while the recombinant tissue preparation, that is alteplase, it is the costlier, and its newer congeners are even more costlier. So first, the difference is in the cost. Second, allergic reactions. As the streptokinase is derived from the beta hemolytic streptococci, the chances of allergic reactions are definitely more, while that is least with the recombinant tissue preparation. And third, but very important, is the systemic fibrinolysis. Because if you look at the mechanism of the thrombolytics carefully, that they are simply causes fibrinolysis. Now, it is not a selective action. Systemic fibrinolysis can occur and it will lead to dangerous complications like the hemorrhage. Now, that is again least with the recombinant tissue preparation. But, dear friends, keep this in mind. They are having a selective action, selective fibrinolytic action on the clot, but it doesn't mean that they are absolutely safe as far as the systemic fibrinolysis is concerned. But they are definitely safer as compared to the streptokinase. So, by looking at this discussion, we come to a conclusion that definitely the recombinant tissue preparations, alteplase and their congeners, they are definitely superior in all the aspects except the cost. But these nowadays these thrombolytics are used only when the facility of percutaneous coronary intervention is not available. Now, why this percutaneous coronary intervention is considered to be superior? There are certain reasons. First reason is that with the use of the thrombolytics, we are not having the 100% guarantee that there is a complete lysis of the thrombi will occur. That is one. While in case of the percutaneous coronary intervention, this is possible. Second thing is that the incidence of the adverse reaction with the thrombolytics, like the systemic fibrinolysis, okay, that is more. Third, there are certain definite contraindications that we will see in the next slide, which is not in case of percutaneous coronary intervention, and thrombolytics are effective on the freshly formed thrombi. So as the time passes, their efficacy reduces. And the lastly, thrombolytics are effective only, as I told, in the ST segment elevated myocardial infarction. While you can use the percutaneous coronary intervention along with the stent placement in any of the type of the acute coronary syndrome. And that's why if the facility is available, then definitely percutaneous coronary intervention with stent placement is considered to be the preferred treatment option over thrombolytics. But if this facility is not available, then definitely thrombolytics are considered to be the next alternative. Regarding the dosage, we consider the dose of the altiplase. Total 100 milligram of the altiplase is given over a period of 90 minutes. Out of this, first 15 milligram is given as a bolus, followed by 50 milligram, 50 milligram over a period of 30 minutes, and remaining 35 milligram given over a period of 1 hour. Now we will discuss about the contraindications for the use of thrombolytics. Okay, and there are certain absolute contraindications, like if there is a history of intracranial hemorrhage, then thrombolytics must not be given. Same way, if there is an history of intracranial tumor or the history of ischemic stroke in the last 3 months, one must not give thrombolytics. If there is a history of head injury or major surgery in the last 3 months, one should not give thrombolytics. And if the patient is having a history of current active bleeding, like in case of a bleeding peptic ulcer or bleeding esophageal varices, thrombolytics should not be given. And lastly, uncontrolled hypertension, because the chances of the subarachnoid hemorrhage will be there, and that's why thrombolytics are contraindicated. Pregnancy is also a contraindication for the use of the thrombolytics. So these are all the limitations for the use of thrombolytics. But at the same time, if the facility for percutaneous coronary intervention with the stent placement is not available, we are not having any other alternative, and this will make a difference. Okay. Now after that, till now what we have done in the hospitalization: 100% humidified oxygen, complete bed rest, then nitroglycerine, then reperfusion with the thrombolytics, and then very important is beta blocker. Actually, all these procedures, I should not use the word procedure, but all these agents should be given simultaneously. It is not like that first you will give this, then second you will give this. No, because it is an emergency condition, simultaneous administration of all these agents will be done. Now, if not contraindicated, beta blockers must be given immediately. Initially the IV followed by the oral. Okay. Now you think, which are the contraindications for the beta blocker? If the patient is having significant bradycardia or even the heart block, then you cannot give the beta blocker. Okay. Now the agents, metoprolol is available as an intravenous as well as the oral, while atenolol is available as an oral. So initially you can start with the IV metoprolol, and later on you can switch over to either metoprolol or atenolol. And what is the rationale? We have already discussed that the beta blockers, it will reduces the force of the contraction, heart rate, conduction, so it will overall reduces the cardiac work, and that's why it can, when in the evolving stage of the MI, when you give the beta blocker, it will limit the spread of the infarct size. This is very important. Second, because of the beta blockers are having the capacity to reduces the sympathetic overactivity, and that mediate the beta blockers can reduces the rate of the impulse generation from the SA node, as well as beta blockers delay the AV conduction. They are very helpful in preventing the ventricular arrhythmias, especially the ventricular fibrillation. And again I am repeating that the most common cause of the death in the myocardial infarction is the ventricular fibrillation, and beta blockers are very helpful in preventing the ventricular arrhythmias, especially the ventricular fibrillation. And beta blockers are also having the cardioprotective action, and that is why, if not contraindicated, for the secondary prophylaxis also, beta blockers must be continued for at least a period of 2 years. Then the next is the AC inhibitor, angiotensin converting enzyme inhibitors. Now, if the patient is hemodynamically stable, especially if the systolic blood pressure is more than 100 mm of Hg, AC inhibitors must be considered, and they must be given, because after the beta blockers, it has been proven by the various clinical trials and studies and statistics that AC inhibitors are also effective in reducing the cardiac mortality. Second thing is that AC inhibitors, we have already discussed that in myocardial infarction, the contractile portion of the myocardium is replaced with the rigid, necrosed portion, which is a non-contractile myocardium. Now there is a cardiac remodeling. Now this can be prevented, or up to a certain extent, this can be reverted with the help of the AC inhibitor. And that's why they are given in the evolving stage of the myocardial infarction, as well as if the patient is having congestive cardiac failure or hypertension, this drug can be given for the long-term management also. Fine. Then anticoagulants. Now the question arises in your mind that here in the myocardial infarction there is a role of thrombolytics. Then what is the need of the anticoagulant? But dear friends, the patient will remain in the bed for a very long period of the time, and it is a definitive, there are definitive chances that in a bedridden patients there are chances of occurrence of deep vein thrombosis, and it may lead to pulmonary embolism. Secondly, anticoagulants may be, now this is not a proven effect, but it may be beneficial to prevent the thrombus extension, the thrombi, and because of which the blockage that has been occurred, if you give in the initial stage anticoagulant, they may be helpful in prevention of the thrombus extension. But for these reasons, only the unfractionated or the conventional heparin is given. And again the dosage regime, here again I have told you that 1000 units per hour intravenous infusion, but the dose can be titrated according to the need. Then yes, very important, intravenous fluids. Because in myocardial infarction, we have to manage the blood volume, we have to manage the tissue perfusion, we have to maintain the microcirculation also, and for that either normal saline or dextrose, or depending on the condition other fluids can be given. But one thing must be taken into the account, that Fluids must be administered very cautiously to avoid the volume overload because the heart is already damaged because of the infarction, and if there is a slightest increase in the volume and which will lead to the volume overload, it will aggravate the condition and it will lead to the heart failure also. Okay, so the careful administration of the IV fluids is essential. Then if the complications occurs, then which are the possible treatment options? There are certain complications, that cardiac failure or the heart is not able to pump because of the infarction. Then you can manage these by decreasing the volume overload with the help of the potent loop diuretics furosemide, or you can give a vasodilator, mainly the nitroglycerine, so which will reduces the preload and the afterload, and that's why the failure heart can be improved. And if these two agents are not effective, then you may add inotropic agents like dopamine or dobutamine for a short period of time. Then next is there may be chances of arrhythmia, heart block can be there, bradycardia or heart block, but this can be managed with the help of the atropine. If there is an occurrence of tachyarrhythmias, then you have to give lidocaine or amiodarone. If there is a acidosis, okay, because of the increased lactic acid production, you can give intravenous sodium bicarbonate infusion. So these are all the possible complications that can be seen in the myocardial infarction along with the possible treatment options. Now, after all, if the patient is recovered from the myocardial infarction and at the time of the discharge, certain medications and certain advices must be given to the patient, and the main aim is to, as I have told, the main aim is for the secondary prophylaxis. It means that to prevent the future occurrence of the myocardial infarction. And first and foremost is the psychological counseling, that is essential. Second is in the non-pharmacological measure gradual increase in the physical activity, and patient must be explained that the over a period of the time after 2 to 3 months gradual increase in the physical activity, and this physical activity must become a part of their routine lifestyle. That is one. Second is the modification of the cardiac risk factor. Very important. Smoking cessation, control of the alcohol, and these three deadly triad, that diabetes, hyperlipidemia and obesity, must be controlled either with the non-pharmacological measures or with the pharmacological measures, and obviously last but not the least, control of the hypertension. Now certain additional drugs must be given to all the patients, and among this first one, tablet aspirin, low dose aspirin 75 milligram daily in the noon. This is having, because the patient is already in a high risk, because there is one episode of myocardial infarction, and it has been proven that because of the antiplatelet action, aspirin will definitely reduces the cardiovascular mortality. Secondly, long-acting cardio-selective beta blocker, either atenolol or metoprolol, it will definitely reduces the occurrence of future episode of myocardial infarction. One. Second, even if the myocardial infarction occurs, the chances of the ventricular arrhythmias and fibrillation will be less. And third, beta blocker will be proven agent for the overall reduction in the cardiovascular mortality. Then AC inhibitors. Okay, again, as I have told you that after the beta blocker, it has also been proven that the AC inhibitor will reduces the cardiovascular mortality. Secondly, AC inhibitors, they are a very effective antihypertensive by as they reduces the total peripheral resistance, and AC inhibitors are also the drug of choice in all the stages of the congestive heart failure. So if the patient is having additional either congestive heart failure or hypertension, AC inhibitors must be given. And if these diseases are not present, still AC inhibitors should be given because they will prevent and up to a certain extent revert the cardiac remodeling. And lastly, the chief culprit of the occurrence of the myocardial infarction is the blockage, and this blockage is because of the atheromatous plaque and superimposed platelet and fibrin and red blood cell. But this atheromatous plaque is the chief culprit, and this consists of the lipids. So one must control or manage the hyperlipidemia with the diet, non-pharmacological measures, and now it has been proven that the HMG-CoA reductase inhibitors, either atorvastatin or any other statins, it will definitely helpful in preventing the future occurrence of the atheromatous plaque. So this is all about the secondary prophylaxis. Okay, so we have seen what is the basic pathophysiology of the myocardial infarction, what are the treatment objectives, which drugs are given before the hospitalization, which drugs are given during the hospitalization, and which drugs are given after the discharge for the secondary prophylaxis. Now it's a time of assignment. What is the ideal time? First question. What is the ideal time period for the administration of thrombolytics in ST elevated myocardial infarction? Which agent will you prefer? Justify your answer. Second is, what are the advantages of percutaneous coronary intervention with the stent placement over thrombolytics? Third, why low molecular weight heparin is not preferred in the acute MI as an anticoagulant? And fourth, which parameters will you check before administration of fluids to maintain the tissue perfusion in acute myocardial infarction? And based on this discussion, you also have to write a prescription. A 54 years old male patient admitted in the emergency department with complaints of chest discomfort since last half an hour, associated with shortness of breath, excessive sweating and anxiety. On examination, patient is having tachycardia and ST segment elevation on the ECG. Patient is hemodynamically stable. His blood pressure is 72 by 98 millimeter of Hg. Patient is diagnosed as having ST elevated acute myocardial infarction, and you prescribe you write a drug therapy for this particular patient. If you are having any comment or any doubt regarding this lecture or regarding this question, you can definitely write in the comment box. You can give your answers also in the comment box. And if you find these lectures helpful, please subscribe this channel, that is Pharmacology in Simplified Way by Dr. Darshan Dave. Keep sharing and keep learning. Thanks a lot.